I'm delighted to have Chris Seymour as our first panelist to speak on this topic. Dr. Seymour is an associate professor in the departments of critical care emergency medicine and the director of clinical and translational science program in the Department of Critical Care Medicine at the University of Pittsburgh. He's also a member of the International Sepsis Forum, and over the last 10 years, his research program is focused on clinical and translational studies involving sepsis, biomarkers, and large electronic healthcare record databases. So thanks again for joining us today, Christopher. Over to you.
Thanks a lot, Gary, and many thanks to the National Academy and the Moore Foundation and others for the opportunity to speak today. I was tasked with discussing data sources, quality, and reliability as it relates to machine learning and AI algorithms to optimize sepsis diagnosis, the focus of today's workshop. These are some disclosures, none that directly relate to the topic, other than we are funded by the Moore Foundation in separate work. So caveats before I begin, I only have 10 minutes to go over a very broad topic, so I will do my best to stay concise. I am not a computer scientist or an engineer. They might have a far more technical take on some of these issues than I will. And I was a member of the International Consensus Conference on Sepsis Definitions, which a few years ago released Sepsis 3, and that will color some of the work that we talk about today. Okay, so for the patient at the bedside, this is actually a cover art from JAMA from a few years ago, showing all the different theoretical and actual data streams that are coming from a patient who's in the intensive care unit, who we might be concerned is developing sepsis. And I think this picture, even from far away, will demonstrate the volume of data and actually the different sources that it may come from when trying to tease apart this syndrome in real time. It's quite a challenge. And in fact, there is almost too much information. And this was a recent cartoon in the Wall Street Journal in sort of demonstrating all of the evidence coming out in COVID, but it's very related to what we're talking about today. There's so much data about our individual patient and patient populations that it's a challenge even for engineers and computer scientists to parse through the noise. So I'm going to just take a very simple approach, though, today and talk about different data types that could go into strategies to optimize sepsis diagnosis. And that includes data from clinicians, structured data in the electronic health record, perhaps unstructured data, and then emerging data types. So I'm also going to use this framework. I was asked to talk about reliability, which is the reproducibility of data across patient sites or clinicians. Quality is interesting. It's interesting how one might define quality in this context, but I'm also going to think about cost and availability of these data sources. And I will move quickly. So imagine this is a round table of clinicians sitting here trying to understand how to identify sepsis patients. Can we inform our models using clinical insight? Well, that's a challenge, and that's always been a challenge for sepsis, in that we're looking conceptually for organ damage, infection, and to distinguish these from health. And when together, they identify the septic patient. Of course, that was the ideal model. This is really the world we live in, where distinguishing between organ damage that's acute from chronic is quite a challenge, as is an infection from health. And therefore, it's very difficult to classify patients on a surface that might have this representation. Okay, so John Uvry at Boston has done some work with clinical vignettes, simple experiment describing sepsis cases in writing and asking clinicians to go ahead and label whether they had severe sepsis, or septic shock. And of course, you can see from these bar charts, proportions are on the y-axis, that there's broad variability in clinicians. And we cannot rely on clinicians alone to diagnose the patient. And I would even argue that relying on what clinicians write in the record is equally challenging and variable. Okay, so in my simple chart, I'm actually going to put no's or red dots for not ideal. Clinician assessments in populations are not available routinely. It's quite costly to have chart review performed. There is absolutely very little reliability across clinicians' diagnoses, and therefore the quality is not what we need for our future machine learning models. So what about structured data? There's quite a bit more information here. This actually formed the foundation of Sepsis 3. So in this work in JAMA a few years ago, 5 different centers contributed data to models that ultimately led to the criteria proposed. That included many colleagues who are participating in the workshop today. But it's not all champagne and daffodils with structured EHR data. And this is one shot, it's a complicated slide that I'll go through quickly, of data at my health system of 22 hospitals that tends to use Cerner. The red bars here, and moving from left to right, are proportions. One column is all patients, the center column is ICU patients, and the right-hand column is ward patients. We see that red bars correspond to the proportion of patients that might have a variable that's abnormal, such as heart rate in the top row. The tan bar corresponds to the patient who has the variable measured, but it was normal. And the white proportions, these are just stacked bar charts, are those in which the variable was missing. And the take home from this very big picture is that there's a lot of white. That means that missing this is a huge problem in structured electronic health record data, and that plays a major role into how we develop machine learning algorithms for sepsis diagnosis. We all have different strategies for missing data. I don't know that there is a right one, but this is a problem that will continue to be one that we face going forward. Okay, when we look at a little bit of a smaller time frame, those missingness rates were by the day. This is just an example showing hourly on the left in work by Emily Brandt, that for even measurements like lactate, they might be measured once in a 6-hour period, and yet our need for a clinical diagnosis is going to happen much more frequently, and we may even need to anticipate that. And so how do we use protein markers or even more complex markers when needing to make clinical decisions fast? It's a challenge. This was work showing that the data still can be used in machine learning models, just proof of concept. It happened to also be in JAMA last year, looking at different phenotypes or subtypes of sepsis. I don't need to go into the details of this other than showing that there were 4 groups identified that had different prognosis and treatment response. And that structured EHR data, therefore, in our chart, I would submit has the most availability, is the lowest cost, and is making gains in reliability and quality. So what about unstructured data? In this context, I'm referring to clinical notes written by clinicians in the electronic health record that might include symptoms or labels provided by clinicians, as mentioned earlier. There is emerging science in this area. This is some work done by Vinnie Liu and Allison Foner and UCSF and institutions on the West Coast, and they use topic modeling to identify individual patterns and treatment responses using words that were in the orders. They didn't go so far as to use natural language processing on text, but again, another proof of concept in a very large database that words might matter, but yet not ready for prime time. And so again, unstructured data is certainly available. It's low cost, but my opinion is that it has uncertain reliability and quality as it relates to these models. And so I'll wrap up with just one slide about emerging data types. Diagnosing sepsis according to Sepsis 3 uses clinical data. But there is no doubt that at the front foot in our research community, folks are investigating longitudinal data streams, as we'll hear from future talks in this session, a variety of protein markers. If you talk about the microbiome and transcriptome, as examples are shown here, there's also the metabolome and many other computational strategies to generate complex data sets. These all have their own limitations of sorts and potential benefits. Many include things like cost, reliability of measurement across laboratories, and availability for these measures to be accessed at the bedside in a timely manner to impact clinical care. So therefore, these emerging data types, and I've only shown a few examples, I think are going to be less available, far more expensive, with limited reliability across centers, and the quality is yet to be unknown, but certainly undergoing active study. And so there are trade-offs, and there is no single data source with optimal quality or reliability. And this was from a paper Derek Angus wrote at the time Sepsis 3 came out, that depending on where you're coming from and why you're building a machine learning or AI algorithm for sepsis diagnosis, there may be different things you value, whether it's the measurement burden, the timeliness, et cetera. And that's shown here for examples like clinical care, clinical research, maybe surveillance, or even audit, performance assessment, and quality improvement. So context matters. And with that, I will wrap this talk and anticipate the panel discussion and questions later. Thank you.